Thank you, John, and thank you, Vinay, for organizing this wonderful family reunion. So I was given the task of talking about genomic-driven treatment advances in Waldenstrom, and we probably need a little help with the advancement. Next. So as many of you know, this is a disease that has quite a bit of heterogeneity to it. Even though it's a lymphoma, much of what it does acts like a myeloma, which is why we're in this session. But it's also important to appreciate that many of the times when we have to treat this disease, it's not because of tumor bulk, but also because of the IgM paraprotein that can cause hyperviscosity problems as well as various autoimmune effects. And for this reason, being able to find the ideal therapy for patients who suffer from this disease can be challenging. And I think what's also been very challenging is, really as a disease that sits between lymphoma as well as multiple myeloma, waiting really for hand-me-down therapies so that we can actually test out on our patients. And so, part of the problem that we faced in being able to, have our own therapies is that for the longest time we lacked a genetic basis. And so if you really want to aspire to find a targeted therapeutic, you really need to know what the etiology of this disease is. And so, taking this into account, many of the hand-me-downs that we were actually hand-me-down had WM-centric toxicities, things that we only appreciated once, our clinical trials started. So even if you were borrowing these, drugs from the lymphoma colleagues or the myeloma colleagues, it really wasn't until we put these drugs into Waldenstrom's patients that we began to understand, what undue effects could be specific to their particular disease. And so perhaps of all the things, that we've appreciated is this IgM flare that occurs with Rituxan. Patients who have high IgM levels can have those levels surge and they can become quite symptomatic. And in some cases, this has led to mortality as well as severe morbidity. We also know that nucleoside analogs, in Waldenstrom's patients can inflict a disease transformation as well as AML and MDS far higher than what's been reported in other diseases, approaching 15 to 20% of all individuals. And IMiDs have been particularly problematic because of peripheral neuropathy with thalidomide, but Revlimid, on the other hand, can potentiate the IgM flare. And in fact, we've given, in our trial with Revlimid and Rituxan, we had patients that were flaring for 6 months even after we stopped giving them drug, and they required ongoing plasmapheresis. And Revlimid can also cause this aggravated anemia that we really don't understand. Their hematocrits come crashing down within a few days of starting Revlimid. And then lastly, bortezomib, which has been such an important addition to our armamentarium, causes far more neuropathy than what we see in other diseases. In fact, in our upfront Velcade Dex-Rituxan study, up to 70% of patients had either grade 2 or grade 3 neuropathy, leading to discontinuation in about 60% of patients. And so for this reason, being able to have a targeted approach to the disease not only will, hopefully result in better efficacy, but also better tolerability. And so to be able to embark on this, we initiated whole genome sequencing studies, and I think as we covered in the session on Thursday morning, the most relevant finding from there was a mutation in the MYD88 gene, which affects about 90 to upwards to 100% of patients. And we not only see this in Waldenstrom's patients, but we also see it in the precursor disease, IgM monoclonal gammopathy, suggesting that this is an early oncogenic driver. And I just want to summarize in this slide, what we've learned about the signaling that's relevant to this mutation in Waldenstrom's. Many of you know that the typical cascade that has been described for MYD88 is that of a signal adapter protein for both the toll receptors as well as interleukin-1. And in this context, usually the Iraq proteins, both Iraq4 and Iraq1, become activated, leading to activation of further downstream transcription factors, ultimately resulting in NF-kappa B activation. But also, as we showed and published last year in Blood, what's very interesting about this mutation, it also engages BTK. In fact, you see in these co-IP studies that MYD88 complexes with the activated form of BTK. And it can, through an independent pathway, also activate NF-kappa B. And then lastly, poor Guang here is cut off here, but thanks to his work, we also now understand that PI3 kinase delta is also one of these downstream mediators, in fact, triggering survival through AKT. And we'll come back to why these are all very important pathways to understand. So with this in mind, we initiated a phase 2 study of looking at ibrutinib in patients with relapsed refractory Waldenstrom's disease. The dose that was used for this study was 420 milligrams a day, and patients could go on therapy until such time as either they were intolerant or demonstrated progressive disease. And so this study actually was open at our institution at Dana-Farber, as well as at Stanford and at Memorial. And these are the characteristics of the patients. The reason why I just want to focus in showing you this is because these were relatively sick patients. IgM 3600, bone marrow involvement 70%, and 60% of the patients had adenopathy. The reasons for therapy are very typical of what we do in Waldenstrom's. Most of the patients need therapy because of anemia. Anemia can be multifactorial in terms of what induces anemia. It's not just occupancy of the bone marrow, but also you can see a variety of other conditions that led to reason for treatment. This actually shows you the data that we presented at ASH. What's very impressive is how fast these IgMs, come down in these patients. And in fact, cycle 2 represents 4 weeks of therapy. And you can see for many of these patients, they've already, entered into a response by the time they're seen, even for the first time back in clinic. And, this is probably the more important slide because I can show you other drugs where IgMs can come down, but no other drug really does what you see here, which is this rapid improvement in the hemoglobin. In fact, for many of the patients, these increases have occurred by the time they're back that first month and continue to occur right through the course of therapy. And coinciding with this in most, but not all patients, is reduction in tumor burden. And this becomes quite intriguing because you'll see that for many of the patients, tumor burden goes down, the median goes down, but there are patients here where there's been very little, if any, change in their tumor burden. And yet, they can have these profound increases in their hematocrit as well as reductions in IgM. And this suggests that there may be alternative mechanisms, perhaps, effects on both tumor and microenvironment, that contribute also to the anemia in these patients. Probably cytokine-driven would be one particular hypothesis. This shows actually the best clinical responses. To date, this is with a median of 9 cycles of therapy. Overall response rate 83%. Major response rate that we define as at least a 50% or more reduction in IgM occurred in 2/3 of the patients. Overall, the therapy was well tolerated. A number of individuals had myelosuppression. These were typically individuals that had a lot of prior therapy, notable being thrombocytopenia. With dose reduction, most of these patients could be managed very, very effectively. As of the time of the reporting just prior to ASH, almost 90% of the patients were still on therapy with a median of 9 months. The reasons for discontinuation are shown here, either non-response or progressive disease, and in some cases, some of the toxicity that I ended up mentioning. Now, given these results, the FDA granted breakthrough status for ibrutinib. This was a very nice birthday present a year ago on February 12th. The hope is that we'll be able to see this through sometime this year. I do want to credit Laurie Kunkel, who's here among us, for really being instrumental in helping to drive this breakthrough designation. Now, one of the first questions that we asked ourselves was, when you look at some people that are responding and others don't, why is it? Is there a genomic basis for this? And I know I presented this data to you, but for those who perhaps didn't see this, the second most common mutation in Waldenstrom's is that of CXCR4, and it's actually in the C-terminal domain. This is that little pigtail in the C-terminus, which is very critical. It's a very critical regulatory domain that affects both internalization of the receptor once it's engaged by SDF1 as well as downstream signaling. And I'll show you some of the data for that in just a second. And about 1/3 of the patients, have this mutation, which involves both nonsense as well as frame shift mutations affecting the C-terminal domain. Now, what we know because of the work of two, very dedicated investigators at our institution, that of Yang Cao as well as Aldo Rocara and Irene Gobriel's lab, is that once this mutation is present, it actually blocks internalization of the receptor and it continues to signal. And in fact, the signaling is really centered around AKT and ERK, both of which are very important survival factors in Waldenstrom's macroglobulinemia. And as Aldo Rocara showed, an animal model that he ended up presenting at ASH, it also promotes trafficking of the Waldenstrom cells that have this mutation to the bone marrow. And so with this in mind, we wanted to look and see what effect this mutation had on clinical outcome in the patients that were on the ibrutinib study. And as you can see here, it actually had quite a significant effect. This shows you what happens to the serum IgM levels, which we use as a surrogate marker for disease in these patients, both for the patients that have the WIM mutation and CXCR4 as well as the wild type. And you can see that the patients that have the wild type CXCR4 demonstrate a more robust response. And this is also echoed in what happens to their hemoglobin levels. Again, with the WIMers, you see a retardation in terms of improvement of hemoglobin, whereas those with the wild type CXCR4 show more robust response. And what's actually even more fascinating is this lymphocytosis phenomenon. We've seen this in other trials with other diseases with ibrutinib, including CLL. And what you see here and what you would expect is that once you've introduced this drug, there's going to be this exodus of cells, and you're going to see this in the wild type individuals, but those that have the WIM mutation that promotes, once again, trafficking, binding, and adhesion to the bone marrow, those individuals do not show this lymphocytosis. And that's actually a very important consideration, because when you look at the responders, they're more likely to lymphocytose than the individuals that don't respond. Again, perhaps echoing the fact that the bone marrow is this safe microenvironment, and that part of at least the activity for this drug may also entail this detachment from the bone marrow sanctioned areas. Now, when you look at the overall response, there is a trend for those individuals that have the mutation to respond, although this is a very small minority of patients, and if we're really going to flush this out, it'll take a lot more than just a handful of individuals that have the wild type MYD88 mutation. But what really breaks down here is when you look at the individuals with WIM. In fact, the major response rate among WIMers is 30%, whereas those that have the CXCR4 wild type, it's 80%. Now, not all therapies, are, affected by this WIM mutation. And one of the studies that we ended up doing where we were able to do this in a prospective manner is that of the study that we reported at ASH with carfilzomib, Rituxan, and dexamethasone. And the reason why we undertook this trial, once again, had to do with trying to find a neuropathy-sparing proteasome inhibitor for Waldenstrom's. And this is just going to review some of the clinical data here. That was presented at ASH. Overall response rate 87%, VGPR or better in about a third of the patients. And overall, the therapy was well tolerated by patients with very little, if any, neuropathy. And that's really the punchline here, is there was no, in fact, there was almost no grade 2 neuropathy. Only one patient had grade 2, and there was no grade 3 or 4. And this was actually a very effective therapy. I know many of us did not get to the ski slopes today, but if we were, you can just imagine riding it down just like the serum IgM levels in these patients that were treated with this, achieving some great responses. I mean, if you look at this carfilzomib combination, very nice responses, very nice improvements in hematocrit as well as reductions in bone marrow involvement. And when you apply both MYD88 as well as CXCR4 testing, you don't really see any difference. In fact, again, among the single wild type MYD88 individual, there was a VGPR that was actually achieved by this individual. And so, it is possible to try to make now, decisions, predictive decisions, using these kind of analyses. And it will take more studies, and it will take, looking at other therapeutics as well to see what the impact of both MYD88 and CXCR4 entail. But suffice to say that, we can exploit this even further. This is actually one of the studies that was conducted in my laboratory by Guang Yang, showing, in fact, that we can actually combine these drugs in a very rational manner, including ibrutinib and carfilzomib, which affect many of the common pathways that we discussed. So the next question that we wanted to ask ourselves was, why are those cells in those patients that I pointed out to you still alive? Here you're giving a targeted therapy, and why is it that they're still alive? And at least one of the hypotheses we initially pursued was the fact that if we had this divergent survival pathway, maybe the problem lied in Iraq. And as we tested patients through phosphoflow analysis, these were tumor cells that we took from patients that had been on ibrutinib for 6 months or more. What we found was exactly what we had hypothesized, that Iraq remained on for most of these patients. And then taking those cells and treating them ex vivo, either with more ibrutinib or a Iraq inhibitor or both, we were able to show that if you were able to hit both pathways, you could increase tumor cell death among these ibrutinib surviving patient cells. And so the kind of work and modeling that we're now doing is to try to identify, the ideal Iraq inhibitors. Ideally, you want something that's going to be able to affect this pathway and that will synergize well with ibrutinib. And so far, at least, what we have at our disposal are toolbox compounds, things that we can't use in the clinic as of now. But those are the kind of development efforts that we're focused on. And these kind of efforts, I think, will pay off because not only do you see synergistic tumor cell killing, but you do see the endpoints of inhibition of NF-kappa B as well as, I-kappa B regulating NF-kappa B translocation. Now, also, the finding of PI3 kinase delta as a downstream mediator of WM survival is also very important when you take into account the drug idelalisib. A.J. Gopal in Seattle just published in the New England Journal, the outcome of patients with indolent lymphomas who were double relapsed or refractory to alkylators as well as Rituxan, and this included also patients with Waldenstrom's. All of these 10 patients were Waldenstrom's, and you can see most of these patients actually responded, about 70% of them. And here too we have a signal, using ibrutinib along with idelalisib to affect both of these common pathways also shows very nice, robust, and synergistic killing. So to summarize here, the main finding out of whole genome sequencing is out of this mutation in MYD88. It affects about 90+% of patients. It's an important trigger of both Iraq as well as Bruton's tyrosine kinase. We see very nice clinical responses that are enduring with ibrutinib. We know that CXCR4, based on these studies, impacts response. And then finally, in a very rational way now, we can go about selectively inhibiting signaling pathways for both MYD88 and CXCR4, and looking at these not only with ibrutinib combinations, but other drugs as well. And my last slide here is just to acknowledge all the folks who have contributed to this work, including my colleague Ranjana Advani at Stanford, Leah Palumba at Memorial, Irene Gobriel, and Jorge Castillo at our institution, as well as many of our scientists and also supporters of our center. And with that, I'll stop and thank you for your kind attention.